shoulder exam. So first we're going to go through the rotator cuff exams. The first one is drop arm testing. So you can either have the patient lift up their arm, or sometimes I'll just help them. And I'll say, go ahead, and I just want you to gradually, slowly lower it to your side. So that would be a negative drop arm test, because he can control it all the way down. If he was to have it up here and kind of like cogwheel down and then drop, that would be a positive test. If he was to bring it up here and then all of a sudden it just drops, that would be a positive, and that would indicate a rotator cuff tear. Most likely the supraspinatus, because it's the most commonly torn, and that's the one that's right here where it impinges the most between the two bones. So that's drop arm testing. Empty can, I'm going to ask the patient to basically pretend like he's pouring out some soda cans, and again, this is neutral. You want to come about 30 degrees forward and have the patient just hold there. Don't let me push you down. And you want them to resist against you pushing down. If they have pain, that's a positive test. If they have weakness, that's a positive test for rotator cuff pathology. And again, usually it's for the supraspinatus. You can relax. So empty can. And then Apley's scratch test. I'm going to ask the patient to basically reach behind your back and see how high you can reach up. So again, turn around for the cameras. And you're just going to mark. So the end of his shoulder blade is right here. So that's about T7. So he reaches about T7 on his right hand. And then go ahead and switch hands for me. And on his left hand, he reaches slightly higher. So I'd say maybe like T5. Are you right-handed or left-handed?
Right-handed.
So typically, the more dominant arm will be stiffer because they have more muscle mass, and therefore it's a little bit stiffer. So, and then relax, and then if you go ahead and take your right, reach over your head and reach down this way. So that you're going to mark, and this is more internal rotation and, I believe, adduction. And again, you'll just kind of estimate, again, your markers are T7, so maybe this is like your cervical. You always check to see where the C7 is, which is the most prominent one. It's probably somewhere right around here. So he was reaching probably somewhere around like T2, T3. And then the other side, always compare, and looks like he's fairly equal that direction. And then the other way was, or no, was that internal?
That's internal.
This is internal and adduction, and the other one's external rotation and adduction, I guess. I'll have to look those up. Okay, so go ahead and turn around. But basically those are testing two different range of motions at once. And then lift-off test. Oh, sorry, I'll have to have you turn around, but you can either do it two ways.
Should I do it to the side?
Sure, yeah. So basically, let me face that way. Oh yeah, to the side, you're right. And then I'll just have him go ahead and push your hand. You can do both same time, yeah. Just push off. As long as they can literally lift off, that's a negative test. If they are basically stuck here and they can't lift off, that's a positive lift-off test, and that's indicating a subscapularis tear. So one of the 4 rotator cuff muscles. And then go ahead and turn around. And if they can't reach behind the back because they're in so much pain, they're like, I can't even get back there, you can tell them, can you just push your hand into your belly? Can you depress your belly down? And if they can't do that, then that would be a positive test, also indicating a subscap tear. So that's all for the rotator cuff. Now we're switching to impingement syndrome. NIRS is where I'm basically going to have the thumb turned down, and what that does, you're rotating the head of the humerus into the shoulder joint and rotating that bicep tendon more into the joint space. And then I'm basically going to hold his scapula back here to give stability to the shoulder, and then slowly lift the arm up and ask if the patient has any pain with that. If they have any pain, that would be positive. If they have no pain, it's negative. The next text is Hawkins. And basically you're going to bring the arm forward and just rotate like this. What you're trying to do again is basically push these two bones together, push the shoulder joint or the humerus bone into the glenoid fossa, and smush those structures to see if you have any impingement symptoms. So Hawkins test, positive would be pain, no pain would be negative. Jurgensen's test. So basically going to ask them to shake my hand. You have their elbow bent about 90 degrees, and you're basically going to pull slight distraction down so that you're going to stretch the long head of the bicep tendon. So you're going to stretch it down, and then I'm basically going to ask you to do supination while I resist you. So go ahead and supinate and I'm going to slowly resist him as he turns his hand over. Because the long-headed bicep tendon also does the action of supination. So if they have pain in the bicep region, that's positive. If they have pain somewhere else, it may not indicate biceps. They should have pain in the bicep region with that test. No pain, negative. Cross arm test, I'm basically just telling the patient to relax, and I'm just going to take their arm and cross it across their body and ask if they have any pain. I'm going to ask them if they have pain in that AC joint. So when I do that, does it hurt in that AC joint? If it hurts, positive AC joint pathology, maybe they have some arthritis, or they've torn a ligament here and they had AC separation. If there's no pain, it's negative. Jurgensen's, cross arms, sulcus sign, so I have you go ahead and turn facing the windows. Sulcus sign is where you're basically trying to distract the humerus down and out of the glenoid joint and just subluxing it slightly. So you just tell the patient to relax as much as they can, and you're basically just going to pull down. And if it was positive, you would see a little dimple. You would see a sulcus sign, and that would be positive for shoulder instability, because they are basically pulling the shoulder out of the joint. But if he doesn't have one, like he doesn't, it's negative sulcus sign. Then we have apprehension. So you're going to tell the patient again to relax. I'm just going to take them and basically try and force the head of that shoulder humerus to pop out that way. So if he has pain or he gives you that look of like, oh my god, don't go any farther, that'd be a positive apprehension test for shoulder instability. You could also stabilize their shoulder and do it this way as well. However, since I'm a little smaller, I feel more stable doing that way. Posterior stress test. Same thing, only you're going to try and push the head of the humerus out posteriorly. Those are more rare. It's most common to dislocate the shoulder anteriorly. So you just tell the patient to relax their hands on the top of their shoulder here. You're going to grab the elbow, grab the shoulder blade in the back. If you turn this way, I'm basically just going to try and force that shoulder out the back. And if they have pain or you can see it kind of sliding back, that would be positive. Basically, they just won't like it, and that'll be a positive test. I think that's it for the shoulder. So that was for instability. And then elbow. Again, I have both elbows out at the same time. I'm looking at the angle. Most people have a valgus angle to their elbows. That's normal. If they've had an elbow fracture, some patients will have a varus deformity. So just check to make sure that's okay. And then for the special tests, we have the valgus stress. So again, you're going to do just the distal part of the humerus here, and then the distal part of your forearm. And you're basically going to apply a stress to try and open up the medial compartment. And you're stressing the medial collateral ligament or the ulnar collateral ligament. So I do it at 0, and you should feel an endpoint, and then you kind of do about 30 degrees and stress it again. And you should feel an endpoint. And again, you compare bilaterally. If it opens up more than that side, and they have pain with it, it's a positive test for instability of the medial or ulnar collateral ligament. And then you basically are going to switch directions and go the other direction. So at 0, and then at 30. And sometimes I'll even do it this way. So just try and relax. There you go. So 0, and then it's easier this way, and then 30. And again, you're testing, for varus stress, you're testing the lateral collateral ligament or the radial collateral ligament. Lateral epicondylitis, medial epicondylitis. I'll have you go ahead and put your hands out straight, and then extend your wrists. I basically just have my patient just resist me as I push you down. And if they have pain with that, over in the lateral epicondyle area, that's positive for tennis elbow, for lateral epicondylitis. Sometimes patients will just have pain when you just ask them to actively do it, and that's also positive. If they're positive, if this hurts them, you don't need to push down on them, because it already hurts. For medial epicondylitis, you have them flex their hand down, and again, you have them tell you not to let you push you away. And if they have pain on this medial epicondyle, where the flexor muscles come and attach over here, that's positive for golfer's elbow or medial epicondylitis. And that's pretty much the elbow. Tenellus. So you have an ulnar nerve that runs just right here, your funny bone, and all you do is you basically tap over there, and you ask the patient, does that bother you, does that hurt? And to be a positive test, it basically has to radiate down in the ulnar distribution, and that would be the pinky and half of your ring finger. And then you also have a radial nerve that runs over here that you could also test too, but for testing purposes, the ulnar nerve is good. And then we'll move on to the wrist. So Tinel's at the wrist, and basically I just tap over the carpal tunnel here where the median nerve runs right underneath the transverse carpal ligament. And you ask the patient, does that hurt? Does that cause any numbness or tingling, increasing your symptoms? Most patients will notice tingling in the thumb, the index, and the middle finger, occasionally half of the ring finger. So that's kind of the distribution of that. Phelan's test is also testing for carpal tunnel, where you get compression of the median nerve. And I basically just ask the patient to put your hands together like that. Perfect. And you're supposed to hold it for 30 seconds and see if it increases. If they increase in numbness, that's a positive test. If it just hurts in the wrists, that's not a positive test. Could mean they just have a bruise in the wrist or a wrist sprain. It doesn't mean they have carpal tunnel unless they have the numbness and tingling into the median nerve distribution. And sometimes I'll just grab my patient's hand too and hold it like this and say, does that increase your numbness or symptoms? So that's Phelan's. Gamekeeper's thumb. Again, this one is a little tricky because you have to isolate the proximal phalanx of the thumb here and the first metacarpal. And basically what you're doing is trying to stress this ulnar collateral ligament here. And so you basically are just stressing that joint. It's hard to see, sorry. It's hard to see, but you're trying to stress there, and then I do both sides, so then I'm testing the radial side as well. But the most common one injured is this ulnar one, and that's called the gamekeeper's thumb. So again, isolating this joint and trying to open up this ulnar collateral ligament, and you should feel an endpoint. Positive test would be it would open right up, and it's pretty obvious. It'll open up, and that would be a positive test. It just opens up. Alright, so fecal size, I just ask the patient to put their thumb inside their fingers and then just gently ulnar deviate. And if they have pain along here, the Decker-Veins region, that is a positive Finkelstein's test indicating tendinitis of the tendons that run along the wrist here. Negative test would be if that didn't hurt at all, no pain. Flexor digitorum profundus, you basically want to do each finger individually to make sure the tendons are intact. So I will isolate the middle joint here and just ask the patient to flex that joint. And then keep it flexed for me, and then hold it there, don't let me push you down. You just want to test it and make sure they can actually hold it. Even if it's partially torn, they may be able to still flex it, but if you have them hold against resistance, you're for sure that tendon's intact. And I'll do that with each joint. Go ahead and flex that one. Again, resist. So I know those flexor digitorum profundus is intact. And then if I'm going to isolate the flexor digitorum superficialis, I will have the patient go ahead and flex that finger down and hold it there. Don't let me push you away. Hold it there. Good. Then you know that that's intact, and that's very important. Same thing with the extensor tendons. You just have them extend their fingers out and make sure they extend all their fingers and they don't have like a mallet finger where this drops down like that. And that will cover you for all finger tendons. And last but not least, the grind test. You're testing for arthritis of the carpal metacarpal joint, the CMC joint of the thumb. You're just going to grab the thumb, push it into the joint a little bit, and just do a circumduction motion to feel if you have any grinding, popping, pain. That would be positive. If it feels nice and smooth, the cartilage is moving very nicely together and no pain, that's a negative test. And that does it for